Hi, everyone. Good afternoon. This is Leslie Cardo with University Health. We're going to get started here in just a couple of minutes. It's 11:59 right now, so we'll give people who are just grabbing their lunch a few minutes to get ready, and then we'll get started. Thanks so much. And a friendly reminder to all to go ahead and please mute yourself so we won't be speaking over the doctor. We'll get started in 1 minute. Thank you so much. Hi, everybody. Happy Valentine's Day. Thanks for joining us for this Lunch and Learn. We're super excited that you're here, and it's going to be an excellent presentation. It's a relevant and timely presentation of atrial fibrillation, or commonly known as Afib, and stroke risk with a special section on COVID-19. My name is Leslie Cardo. I'll be your moderator this afternoon. Thank you for registering for today's event and for spending your lunch break with us. First, we want to let you know that this presentation will be recorded, so it'll be available for viewing after the event. We will also take questions following the presentation, or more specifically, the doctor will take questions. You could go ahead and list those on the chat box on the side. Also, we want to let you know that in honor of Heart Month and Valentine's Day today, we're offering cardiac CT calcium score screenings for just $35. You can purchase that screening at mdsave.com. That's M as in Mary, D as in David, the word save, S-A-V-E, all one word, mdsave.com. So this is a special offer only available for purchase in the month of February. However, you can use it at any time. So please don't miss out on this life-saving screening, which could be vital to you or someone you love. So now on to our esteemed speaker. It is with great pleasure to introduce to you University Health's very own Section Chief of Cardiology, Dr. Angel Lopez-Candales. Dr. Lopez-Candales graduated from the University of Puerto Rico School of Medicine in San Juan, Puerto Rico, and completed an internship and a residency at Veterans Administration Hospital, also in San Juan, Puerto Rico. He completed a fellowship at Jewish Hospital at Washington University in St. Louis, and is board certified in internal medicine, cardiovascular diseases, and electrocardiography. He currently serves as a professor of medicine at the University of Missouri, Kansas City School of Medicine. Please welcome me in joining Dr. Angel Lopez-Candales.
Thank you, Leslie, for that introduction, and I hope you can hear me well. And I echo Leslie in saying to all of you, happy St. Valentine's and a happy Heart Month. And all of you that are eating, bon appetit and enjoy your lunch. We're going to be talking about atrial fibrillation and stroke, and the title of this is Help My Heart Skips a Beat. For the sake of clarity, not all heart skips are atrial fibrillation, but since not everything is created equal, heart skipping needs to be evaluated appropriately. So anytime that you or somebody you love or somebody you know is complaining of skipping beats, it's important that this can be brought to the attention of a healthcare professional. In this next slide is a representation of what atrial fibrillation looks like. In the top panel, there's a normal heartbeat in which you can see that not only in the electrocardiogram just we see regular complexes, but the conduction to the heart is normal and is paced at a regular rhythm. In contrast, in here in the bottom panel, atrial fibrillation, there's a chaotic rhythm in which different beats are coming at the same time. So try to imagine somebody that is trying to slow dance and somebody's trying to do some rock dance at the same time between the top and the lower chambers of the heart. So unfortunately, that is going to create some problems. Now, we're going to be talking in the next 45 minutes what atrial fibrillation does to your heart and what is the relationship with stroke and what COVID has to do with any of this. So atrial fibrillation comes in 4 flavors, if you wish. There's a paroxysmal here, in which is just recurring and it happens from time to time. There's the persistent atrial fibrillation that can be sustained and can be there for a week and then disappears and then comes back again. There's the long-standing persistent, in which it can happen on and off or continuously for up to 1 year. And then there's the permanent atrial fibrillation that unfortunately is kind of want to stay and doesn't want to go back. And unfortunately, you have to make the decision between the patient and your doctor if we're going to do anything about it or this is it, and we're going to have to live with atrial fibrillation. So that's why it's important just to, once we're aware that something is not natural and something is going on, that we take care of this, because if not, it becomes a chronic problem, then we cannot do anything about it. So in terms of symptoms, and again, the normal rhythm of the heart in terms of the electrocardiogram compared to the atrial fibrillation. But the most important thing is that usually is a shortness of breath. And who doesn't have shortness of breath? That is actually a universal symptom for a lot of things. And the same thing happens with atrial fibrillation. Not everybody is going to feel the palpitations or the irregular beating of the heart. Some people might just feel dizzy, and some people might just feel only fatigue. But when we see the big picture, the unfortunate thing is that in here, 15% of patients, up to 20% of patients, might not feel anything whatsoever. And the problem with that is that if we don't have a warning system to alert us that something is going on and the rhythm is irregular, that places the individual at risk of having a stroke. And that is a catastrophic complication of atrial fibrillation. Atrial fibrillation is the most common arrhythmia worldwide. Unfortunately, a lot of people remain undiagnosed, and this problem goes under the radar until something happens, like a heart attack, heart failure, or a stroke happens. And the problem is, as we get less young, I don't like to use as we age, as we get less young, the prevalence of atrial fibrillation increases, and the costs associated with the treatment of atrial fibrillation also increases. In this graph, I can show you that once we start in the age of 50 for both men and women, the incidence and the prevalence of atrial fibrillation increases exponentially. Now let's concentrate on women right now, because this is an important under-recognized problem among women. 33.5 million women are affected worldwide. And this is a problem that happens also here in the United States. And 9% of people over the age of 65 are going to have or have already atrial fibrillation that are not aware of. So this is not a problem that is unique to the world. It happens also here in the United States. And in this map, you see that the concentration of the population that happens to be from the mid to the eastern part of the United States also is affected with atrial fibrillation. And I can put map on top of map on top of map. Not only this is only atrial fibrillation, but it's also diabetes, hypertension, obesity, so on and so forth. So what are the differences between males and females in terms of atrial fibrillation? I just said at the outset that atrial fibrillation is under-recognized in females. But as you can see in this graph, females have more risk factors for having atrial fibrillation. And the unfortunate thing is that sometimes not only women are more stronger than males, but they don't want to accept that something is going on and they don't seek medical attention as males do. So what are the risk factors that we need to be looking for? Well, elevated body mass or obesity is one of the most recognized risk factors of atrial fibrillation. Hypertension is also a very important risk factor for atrial fibrillation, as well as diabetes, having already coronary disease or a blockage in one of the vessels supplying blood to the heart, valvular heart disease, and of which aortic stenosis is one of the most common ones, is the most common valvular disease, again, as we get less young. Heart failure, or the pumping action of the heart being compromised. And again, the prevalence of these risk factors are quite different and are more significant in females rather than males. So when we look at both, the problem is that for females, we have worse symptoms and quality of life and an increased risk of complications, particularly stroke. And once the stroke happens, particularly in females, they have an increased mortality. So that is why it's so important that we recognize atrial fibrillation as something that we need to be aware of and be cognizant of the fact that we need to go to the doctor on a regular basis to make sure that we don't have this complication. So once again, let's look under the magnifying glass and what is different between females and males. So we don't recognize that much because women don't come to the doctor that often compared to males. But we recognize, though, that women do have a higher incidence of high blood pressure and involvement of the valves, as well as blockages in the coronary arteries that present later than males. So this places women at risk for having atrial fibrillation. Also, the body habitus and the structure of the heart compared to males places women at risk of atrial fibrillation. And once again, the hormonal difference makes a huge difference in placing women at risk for atrial fibrillation. Genetics have not been consistently reported as being significant, although if you have a family history of atrial fibrillation, most likely this is going to be passed on to the next generation, and you could be at risk of having atrial fibrillation. When they present, women usually are more symptomatic, particularly of those symptoms that we mentioned before. And symptoms can be atypical, like the presentation of a heart attack that is not the usual for males. And the rates of the heart rate are going to be faster in women than in males. Unfortunately, and I want to reiterate this as many times as possible, so this will be the take-home message. There's an increased risk of stroke, an increased risk of heart attack, and increased risk of dying from having atrial fibrillation in females compared to males. So we can go and look at different criteria, but I would like to zoom in some risk factors that are very important.
Yeah.
You already have age, the obesity, your history, family history of atrial fibrillation. Those are things that we cannot control very well, but there's some risk factors that we can actually control. And for those that have already involvement of heart disease, being the valves, being blockages, having diagnosed with sleep apnea, or having already undergone cardiac surgery, should be at a heightened approach of saying, I need to be checked and make sure that I don't have or have developed atrial fibrillation. Also, those with diabetes, hypertension, those that are obese, of heart failure, any kind of heart failure, being the preserved ejection fraction, or those that have reduced pumping action or heart rep, are also at risk of having atrial fibrillation and should be checked on a more regular basis. Alcohol, the use of drugs, and have high thyroid is also an important criteria in terms of producing atrial fibrillation. So what are the treatments? Doctor, I do have atrial fibrillation. What are my options? So the first option is shocking you out of the atrial fibrillation. They put paddles on top of your chest. We give sedation so you don't remember what's going on. You don't want to know when somebody shocked you with a high electrical discharge. And when the paddles are put in certain aspects in relationship to the heart, we can restore the rhythm from being a chaotic rhythm. We produce a shock, and then we restore the atrial fibrillation. And this can have long-lasting effects by itself or with the use of medications. There's also ablation techniques that are more invasive. We go with catheters inside the heart. We look for the areas of the electrical glitch, and then we create areas of electrical burning. So the gaps can be closed and the atrial fibrillation wavelets no longer are in place, and the atrial fibrillation then resolves in 90% of the time. In addition to that, since there is the propensity of having clots and having a stroke, not only we can give patients medications or anticoagulants to prevent the stroke, we can put devices inside the left atrial appendage. That is the most common site for having clots form that will end up in the brain. And we can close this left atrial appendage with a device that prevents the formation of clots and eventual embolization to the brain. In terms of, we have rate versus rhythm control. What are the difference between males and females in this regard? Remember the electrical cardioversion, the utilization and the outcomes are the same between both sexes. A recent review of the literature says that even when they have similar results, since women don't come to the doctor as often as males, the utilization of electrical cardioversion is used less in females rather than males. But when used at the same level, they have similar results. Rate control with medications is more common attained in women rather than male. The rhythm control might be associated with a higher risk of adverse events. And what it means is, if I'm trying to do the cardioversion or the ablation techniques, women might have a higher risk of adverse events with stroke or bleeding issues once the anticoagulation drugs are started. As I mentioned before, the electrical cardioversion might be used less common in females than in males, and the catheter ablation might be less commonly used in women than in males, with a higher degrees of complication, and that has to do with the body size of females. Those are petite, might have a higher incidence of complications compared to regular body size females. In terms of stroke prevention, warfarin, as well as the other, what we call NOAC, Eliquis, Xarelto, the prescription rates are similar. The risk of bleeding with warfarin might be a little bit higher than in males. And the efficacy of Eliquis and Xarelto versus aspirin have been confirmed in several trials, being superior and having less bleeding complications. In terms of the ablation techniques, I would like to make just a few comments. The primary efficacy or the endpoint, unfortunately, increased failure rate in females compared to males is up to 37%. So it is important that we try to prevent these rhythms with medications, or try to identify these rhythms before we have to go into an ablation procedure. The rehospitalization, or how many times we have to go into the hospital with atrial fibrillation, becomes problematic in females. And again, it's close to 36%. And it's more important in females that have high blood pressure. And the need for a repeat procedure also increases in females with a risk of 3% per year. So again, it is important first to diagnose a problem and see if we can control it with direct current cardioversion. That is more useful in females than in males. It's less used because, again, females don't like to come to the doctors. And we can treat this with medications and have much better response in males before we need to go into a more invasive intervention. So now we're going to spend a few minutes talking about stroke. And stroke in women is, again, a very significant and catastrophic problem that needs to be addressed, and again, go hand in hand with atrial fibrillation. So what is a stroke? Stroke comes in two flavors, if you wish. One is like it manifested in this video image, in which there's a clot that occludes the blood flow to the brain vessels, creating an infarct. And there's also that when the vessel breaks and there's bleeding into the brain. So it can come in two flavors, either an embolic phenomena that creates an infarct, or when there's a rupture in the vessel that creates a bleeding. And both could have catastrophic implications. It is very important to recognize the signs and symptoms of a stroke. The most significant and the most common one is going to have speech difficulty, arm weakness, gait intolerance, poor balance. And the important thing is, and the take-home message with stroke is that time is essence. It's very important that once one of these symptoms is identified as setting here, we need to be fast. If there's loss of balance, if there's trouble seeing, I have seen double, I cannot focus, I have face drooping, I have difficulty and weakness in my arms or legs on the same side, I have slurred speech, my tongue is deviated to the side, you need to make that 911 call right away, because time is essence. The more you delay the call, the more you delay institutional therapy, brain cells die and brain cells don't come back. So that is critical. And this is to show that the stroke impact affects all classes, whites, African Americans, Hispanics, Asians are not here represented, but in the same way and magnitude. The same way, same age group, and it's a significant impact. And we need to be very aware of those symptoms so we can institute therapy right away to save brain cells. We know we pay a lot of attention with particular importance of breast cancer in females. And this is a representation of how many females die per year because of breast cancer. Look at how many number of females die from a stroke each year. And we pay a lot of attention for breast cancer, but look how many females succumb to stroke. And it's very important that we recognize what risk factors place women at risk for a stroke. Pregnancy, elevation of blood pressure during pregnancy, or the development of preeclampsia places women at risk of having stroke during pregnancy or later in life. The use of birth control pills also have been a recognized risk factor for stroke in women. Hormone replacement later in life also places women at risk for a stroke. Having migraine headaches and the use of cigarette smoking have been shown direct correlation with the development of strokes. And we have been mentioning in a few minutes ago the development of atrial fibrillation. And just remember, 15 to 20% of patients are not aware that they have atrial fibrillation, and the first presentation can be a stroke. So put everything in perspective. Every second, 32,000 brain cells can die. And as I said before, brain cells don't come back. So when they die, that's it. Every minute, 1.9 million brain cells die. Within 12 minutes, 23 million brain cells die. So the more we delay the onset of appropriate therapy, the more catastrophic complications we're going to have, and motor and sensory deficits are going to occur without any hope of recovery. So what are the differences between male and females in terms of stroke? Well, women have a higher prevalence of stroke than males. The highest burden of stroke lies with women in low and middle income families that unfortunately don't have the resources to understand their situation, to do anything about it, or to seek help when they need it. And strokes outcomes differ based on gender. Greater gender inequality unfortunately equals to a higher stroke mortality. In 26% of the country's stroke mortality rate have been higher in females rather than males. Stroke kills more than twice as many American women every year as breast cancer, as I showed before. More women die from a stroke than men, and they have a higher risk of having a lower expectancy. And also they have a greater disability after they have sustained a stroke compared to males. Which females are at risk? Even though women between the ages of 45 to 55 have an increased risk of stroke, there's a significant increase in younger females between the ages of 25 to 30 years of age with late pregnancies, particularly, as I mentioned before, they have associated elevated blood pressure or preeclampsia. Unfortunately, and I have to say this again and again, people don't recognize the symptoms, and this is the same thing as we talked about atrial fibrillation. And again, atrial fibrillation and stroke go hand in hand. 40% of stroke patients can name a single sign of stroke or a stroke's risk factor, and that is unfortunate. We need better education of the community, better education of our family members to recognize a stroke. 75% of stroke victims misinterpret their symptoms. Maybe I have a migraine headache. Maybe I have a really bad headache. I just woke up and I was on my side. That's why my arm is a little bit numb. I have a little bit of problem recollecting names because I'm getting less young than before. We have to be aware of those symptoms. And as time passes, this becomes a problem. 86% of patients believe that their symptoms are not serious enough to request urgent or seek medical attention, and that could be catastrophic. People don't know the urgency. They deny their symptoms, think that nothing can be done. They worry about cost, think that symptoms will go away, fear or don't trust hospitals. And now in the COVID era, a lot of patients miss coming to the hospital because they didn't want to get infected. And unfortunately, they die at home from a stroke. So again, time is of essence. Every second that you delay treatment for having stroke, it equals to 2.2 hours of a healthy life that you have missed. And as I said again, this time cannot come back and you cannot replace brain cells. What is the intervention? We can give blockbusters that can lyse the blood clot that is causing the inability of the blood flow to go to the brain. But the most important intervention is the endovascular thrombectomy that can mechanically break that blood clot and restore the blood flow to the brain. This graph just to show the representation over time, looking at how bad the outcomes are as we wait in time. If treatment is actually placed at the same time that symptoms occur, excuse me, this will be the great and the most beneficial of them all. But as time passes on, as I mentioned before, we lose brain cells and we're unable to bring them back. And we have greater motor and sensory deficits that are not going to be usually being able to restore. 10% of stroke survivors recover almost completely. 25% recover with minor impairments. 40% experience moderate to severe impairments requiring special care. 10% will require care within either a skilled care or long-term care facility, and 15% will die shortly after the stroke because of catastrophic central complication with the respiratory centers. So again, just to repeat, because repetition is always important. The time of menopause for female is important risk factor for the development of atrial fibrillation as well as stroke. Hormone therapy, smoking, use of birth control pills, patients with diabetes, patients with elevated blood pressure and preeclampsia during pregnancy, the presence of lupus or autoimmune disease that affects multiple organs, rheumatoid arthritis, and the development of migraine headaches before the age of 55. All these places women at risk for both atrial fibrillation and stroke. And again, 15% of patients with stroke have a prior atrial fibrillation. And the incidence depends on the age of the patient, particularly the female patient between the age of 65, younger or older than 65. Smoking has always been a concern. Doctor, do you think that there's good literature to place smoking as a risk factor? Yes, as a matter of fact, there's significant data to show that smoking not only is bad for your heart, it's bad for the development of atrial fibrillation, but it's also bad for the development of stroke. And all these studies have shown, and here for both women and males, that the presence of smoking increases your risk of having a stroke. So now with COVID, in the last few minutes, I would like to review what are the links between COVID and atrial fibrillation and stroke, as we have been discussing before. So in terms of atrial fibrillation, unfortunately, as the magnitude of the respiratory and pneumonia problems present in patients with COVID pneumonia, the same thing applies to the involvement of the heart. As the involvement in the lungs increases, the more significant cardiac abnormalities are present. More importantly is inflammation of the heart muscle, called myocarditis. It can also occur inflammation of the sac surrounding the heart, called pericarditis. The involvement of the lung tissue in interstitial lung disease can result in a blockage of the blood flow to the heart, causing a heart attack, also causing a stroke. And then there's also the development of heart failure directly secondary to this inflammation of the heart or myocarditis. And at the same time, increases the presence of atrial fibrillation. And the presence of atrial fibrillation as a consequence of COVID is more significant, more resistant to treatment, and with heart rates that are faster that compromise not only the respiratory status, but also the cardiac hemodynamics. That means blood pressure is dropped, the patient requires inotropic support and longer hospital stay with increase in morbidity and mortality. The cardiovascular complications that we have seen in the last 2.5 years as a result of COVID is that there have been a significant increase of 8.8% in all causes of cardiovascular mortality. Almost 8% in the development of new onset atrial fibrillation just because of COVID, 3% of myocardial infarction that are related to blood clots in the blood supply to the heart, almost 2% increase in new heart failure or decrease in the pumping action of the muscle of the heart, and 1.3% increase in the chance of having a stroke as a result of blood clot, because there's a significant correlation in the infection rate of COVID and the development of blood clots. So here's a figure that represents the relationship that the COVID infection has, not only in the systemic inflammation, but also in the result of atrial fibrillation. All these markers of inflammation affect the cardiac structure and the electrical properties of the heart and creates the milieu to develop atrial fibrillation. The use of drugs can also prolong the electrical signal in the heart, resulting in atrial fibrillation and other malignant rhythms that can cause death. So atrial fibrillation, atrial flutter, that is a regular rhythm from the right side of the heart rather than from the left side of the heart, like is atrial fibrillation. And other supraventricular arrhythmias have been associated with the development of significant COVID symptoms. There's also the development of complete heart blocks. That means that there's no electrical activity between the top and the bottom part of the heart, and some patients might have required the need of a pacemaker during their COVID infection, or cardiac arrest, meaning that the inflammation of the muscle of the heart have left cardiac collapse, and patients are not able to pump the blood, and they can succumb from cardiac arrest. In the same way, COVID infections, as I said before, have been significant in the arena of stroke and the development of stroke. Not only the embolic stroke, but also the hemorrhagic stroke. And the all-cause mortality of COVID-related stroke mortality has increased by 15% compared to those patients that were not COVID positive. Data analysis of almost 42,000 patients from 458 hospitals, comparing COVID versus non-COVID patients. You see that not only patients that were COVID positive were somewhat delayed to go to the hospital, but treatment was also delayed, and the mortality was increased when compared to patients that did not have COVID. And this graph, what it represents is that the higher magnitude of the viral load of COVID have resulted in more significant mortality and morbidity in patients, leaving patients with longstanding COVID symptoms after their recovery, significant shortness of breath, cough, and persistent oxygen requirements, significant anxiety, depression, and sleep disturbances, and post-traumatic stress disorder with headaches, palpitations, manifested as atrial fibrillation, chest pain, and heart attacks because of the thromboembolic phenomena or the blood clot formation as a result of COVID. There have been also an increased incidence of chronic kidney disease in these COVID patients. And the formation of the blood clot directly as a result of the inflammation of the walls, and all these particles not only creates this cytokine storm that creates all the difficulties that we have seen in managing patients with the inflammation of the lungs, but also inflammation of the heart and inflammation of the brain and disruption of the blood flow to the brain, causing strokes. So I think that we have left enough time if there's any questions for the audience to address atrial fibrillation, stroke, and what is the link that COVID has between atrial fibrillation and stroke in cardiovascular disease.
Hi, Dr. Lopez-Nogales, it's Leslie again. My question is, what if I've been listening to this and I just feel like I haven't been doing enough for prevention, or I know that I'm not healthy, or I know that my diet isn't good and I'm a smoker and all these things. Where does one start? Because it can seem a little bit overwhelming.
That is a great question, and it's very overwhelming. And not only is to you can say for yourself, I don't have time to go to the doctor. I have so many things, and maybe I don't feel good because I have to do so many things. I hear that from my wife. You need to take care of the kids, the grandkids, you have to take care of everything. I don't have to take care of myself. I don't have time to do that. We have to take time. And you need to take time for those same family members that you are taking care of. You need to be healthy so you can take care of them. So you need to have time to go to your primary care doctor. And if you have the family history, or you have already been diagnosed with risk factors that I have been talking about, particularly diabetes, hypertension, you're a smoker, have a family history of heart disease, not only you should be seeing your primary care doctor, but you should be seeing your cardiologist. So you can step up what other diagnostic tests needs to be done to make sure that what are your risks of having either atrial fibrillation, any other cardiac condition, or be at risk for a stroke. Did that answer your question?
Yes, that did. And I have a couple more questions coming in. And while I read them, I'm going to ask you one more. For people who are hesitant to come to see a physician and come to the medical center, typically a first cardiology appointment with you entails what? How much of it is just a conversation, and is there testing right away, or what would someone expect in that?
Just a phone call. I want to see the doctor. I would like to see an appointment. I would like to have an appointment. Sometimes this day and age, we don't have the time. We can do a telemedicine phone call, and that will be enough to identify what risk factors you have, and do we need to see you soon? Do we need to have a test before you see the doctor? Or we can reassure you and say, okay, there's some things that we can do, and you don't have to see us right away, but you can do this in between your next appointment and the next test that you need to have. Does that answer the question?
Yes, thank you very much. So one of the questions, I know this is in the news a lot lately, is broken heart syndrome. I know there's a medical term for that, but the question is, I just lost the question. The question is, how do you explain strokes caused by broken heart syndrome with no blockages or no bleeding? Is that something you've seen? Are you seeing?
Right. Yes. So Takotsubo is actually the medical term for the broken heart syndrome. And by the way, it's far more common in women than in males. And the most likely presentation is that of a heart attack. It's that severe chest pain that usually women don't have with a heart attack. But in Takotsubo is that significant pressure in the middle of the chest that is associated with an intense emotional situation. That is illness, the death of a family member, of a relative, or a friend. I have a couple of patients that they lost a dog that they felt that the dog was more important than any of the other family members. They were involved in a car accident. They were broken the news of a new diagnosis of breast cancer. Their husband had been diagnosed with cancer. Any of those strong emotional scenarios will trigger a Takotsubo or broken heart syndrome. And the presentation, as I mentioned, typical chest pain, the sweatiness, the shortness of breath, the nausea, the dizziness, that will prompt an immediate visit to the emergency room. And it will present as a heart attack. You have patient A and patient B with a typical blockage, and then Takotsubo, they have the same clinical presentation. The electrocardiogram is abnormal. The blood markers are going to be abnormal. They need to be taken to the cath lab immediately. The patient with a blockage, we're going to find a blockage that we're going to open up. The patient with Takotsubo, we're not going to have a blockage. But what we're going to find is that the small vessels are the ones that are the culprit lesions, and they're not allowing the blood flow to go to the muscle of the heart. So we cannot open the blood vessels, but we can treat patients with Takotsubo with medications to restore the blood flow and to prevent the development of heart failure and any other complications like will be a stroke, because when the heart doesn't work properly, then you form the blood clot within the cavity of the heart, and then that can result in a stroke.
Thank you. One of the questions is about that, the calcium screening that is available on MD. Someone asked where to find it. It's M as in Mary, D as in David, the word save, SAVE. So mdsave.com. It's available to purchase through the month of February. Can you tell us just a little bit more about what calcium cardiac screening does?
So this is a very inexpensive test that it takes only a few seconds to get. It doesn't involve the injection of anything. You just go and have it's a CAT scan. Hold your breath for less than 30 seconds. They take your scan and you're on your way out, and wait for the doctor to call you with the results. The most important thing is in the calcium score is to get 0. That's the only test that you want to have 0. In school, you didn't want to have 0 in any of your tests, but this is the one that you really want to have 0, because that means that your risk of having a heart attack within the next 5 years is almost 0. As the number increases in your coronary calcium, the risk of having a plaque that is significant increases. Okay, doctor, I do have a plaque that is 10%. Okay, there's not that much that we can do about it, except treat you with aspirin, change your lifestyle in terms of your medications, and we might have to put you on a statin. I will put you on a statin that most people don't like to be on a statin, but as the number increases, and I'm talking about in the 100 and the 1,000 range, those are the patients that have a significant amount of damage already in some of the vessels. And those are the ones that are going to be at risk of having a heart attack. And those are going to be the ones that are required a statin. And I use the coronary calcium to determine, one, do you have the risk of already having significant atherosclerotic disease? And two, if I need to treat you with a statin. Three, if the number is significant, we'll do a stress test to see if the area that has a significant score in any of the vessels is already having compromising the blood flow to the muscle of the heart. If you're having symptoms, if you have a high score, and I do a stress test, and I know that that area has a compromised blood flow, the next step will be doing a cardiac catheterization to then make sure that a stent needs to be put in to make sure that we can restore the blood flow and prevent a heart attack from happening.
Thank you. I've always wondered, what is a stress test and how is that done?
So there's different modalities. One, if you can walk on a treadmill, that will be the most ideal stress test. And we can do stress tests just walking on a treadmill if you have a normal electrocardiogram. If you don't have a normal electrical signal, we can couple the treadmill stress test with either an echocardiogram to see the pumping action of your heart before and after you do the exercise, or with a nuclear tracer that we inject and we take pictures before and after, and then compare how the blood flow is. If we're using the tracer, if I'm using the stress echo, I see how the pumping action is before and after you exercise. In that way, not only I can measure what is your exercise tolerance, what is your blood pressure response, what is your heart rate during exercise, do you have atrial fibrillation with exercise? But most importantly is if you are at risk of having some blood supply issues that might identify you at risk of having a heart attack. So the stress test is very useful in somebody that is having symptoms. They're not so typical. They're typical, but not enough all the times. You have the risk factors, and I can stratify you from a low risk to an intermediate risk to a high risk that we need to intervene and do something right away to prevent a heart attack.
Thank you. A few more questions. Someone said, I have tried losing weight and I'm not. What else can I do to decrease my risk of stroke?
So obesity is very prevalent. Actually, it was a pandemic before COVID many years ago, and it's very difficult to lose weight. And the most significant problem that we have is that we put too much pressure on our patients. We tell them that they need to lose weight, and then we'll see you in six months, and when they come back, they have only lost 1 or 2 pounds. The realistic point of view is that it's very difficult to lose weight. As we get less young, the metabolism slows down, so it's getting even more difficult. So there's several medications that have been now approved and are in the process of being approved by the FDA to lose weight, but they also take time. And the weight reduction is usually 12%. So if I'm realistic, 12% of weight loss is going to be something significant, and what I'm expecting to doing in 1 year. There's the keto diet right now that is also very popular and has been associated with significant weight loss with any significant side effects, as all these new medications are in the market right now. So we have to be realistic. What are we talking about? Are we talking about that we need bariatric surgery, or that with a keto diet? And once we have made sure that we don't have any cardiovascular risk factors that have been already checked out, meaning I have good blood pressure, I have a healthy heart in terms of my calcium score, I had a stress test and I don't have coronary disease, I can go ahead and have a supervised exercise program to lose weight, and have in mind that at least 12 to 15% of my weight loss is going to be probably attainable in a year, I can do this on a regular basis and make sure that I don't have sleep apnea, because patients with obesity also have sleep apnea. We didn't touch about sleep apnea. It's also unrecognized because nobody wants to accept that they snore. I don't know if I snore unless my wife tells me that I snore. So you have to have a partner to tell you, oh, by the way, you do snore. And yes, you actually do stop breathing when you're sleeping at night. So sometimes we don't recognize that we might have sleep apnea, and not only snoring, but I do have headaches. I have significant nightmares. I would like to take a nap in the middle of the afternoon. Those are all symptoms that suggest sleep apnea. And sleep apnea is associated with atrial fibrillation. Sleep apnea is associated with heart failure, and sleep apnea is also associated with strokes. So they're all related in this universe of obesity and the pandemic of obesity as well.
Question, will AFib diagnosis cause enlargement of the heart? And if so, what's the risk associated with that?
So the atrial fibrillation diagnosis will not increase your risk of having a heart failure, but not having a good treatment for atrial fibrillation will undoubtedly end up in heart failure. Because as the heart rhythm becomes desynchronized, then the muscle of the heart is not able to pump regularly. So eventually, not having atrial fibrillation treated accordingly or unrecognized will eventually develop heart failure. And that increases your risk of having a stroke even higher.
Another question is about heredity. You touched on this a little bit ago. Doesn't the viewer said that she has a brother and a father with AFib, and does that mean she should be screened? What should she do to take action? Does she need a cardiologist appointment right now, or should she go to primary care? What should she do?
So again, the genetics of atrial fibrillation are not cut in stone and that clear like with other conditions. But if there's already a father and a brother, there's a good likelihood that atrial fibrillation might develop. And you have to look at what age their family members develop atrial fibrillation. There's no rush to go and look for medical evaluation right away unless you have already the symptoms that I talked about. But remember, 15 to 20% of patients are not going to have any symptoms. So what patients usually are doing these days before going to the doctor, obviously they don't have any symptoms, they usually use their watch devices, even the Fitbit, the Apple, the Cardiomobile, and they look for atrial fibrillation. And those are actually helpful devices these days that can help the patient and help the physicians, if they have a good connection, if they haven't connected to their doctors, to say, hey, I have objective evidence that I do have irregular rhythm of my heart from time to time, and then I need to be seen by a doctor right away. Actually, a month ago, I did have a patient that her first manifestation of atrial fibrillation was her Apple Watch. And she noticed that every morning there was a recording of an irregular rhythm from the night before. And that prompted having a Holter device. And the diagnosis of atrial fibrillation was confirmed, and now she's in appropriate treatment.
I was going to ask what your thoughts were on the new technology that's wearable and seems so easy to access, but that it's a good warning sign, a good clue that you need to see a doctor.
So, great question. The technology has actually improved from its inception. I do believe that 7 years ago, when the first Apple Watch came in, it was not reliable, but technology has improved. And I'm not with any company, but the ones that I did mention, the Apple Watch, the Fitbit, and the Cardiomobile have actually improved the detection potential. And they're raw, but actually good measures that can identify atrial fibrillation before more accurate device measurements can be done in your doctor's office.
Thank you. I think this is the final question, and then anything else if you want to tell us. This last question says, I have a family member that's struggled with bronchitis and has ended up with long COVID. or COVID a long time ago, but they're still dealing with after effects. Will that possibly get better with time?
So remember that we have been in this COVID pandemic for 2.5 years. It looks now forever. I don't even remember what was pre-COVID. But unfortunately, as time has gone by, we have now collected data 1 year post-COVID. And unfortunately, there's some patients that a year after having COVID, they still have long-lasting effects. So it's too early to tell for how long these COVID manifestations will remain on patients. So we're looking for more data to come. But in this particular case scenario, I would say that if you have already a pre-existing lung condition and you were infected with COVID, particularly with COVID pneumonia, the lung tissue, also like the brain cells and the heart muscle cells, don't recover. And whatever damage was done probably is not going to get better. So if there's already some problem with oxygenation, that is not going to get any better. And there's ways to actually improve symptomatology with pulmonary rehabilitation. But then again, it has to be seen by the pulmonary doctor to seek evaluation and see what other forms of treatment can be actually used to improve symptoms.
Thank you. Thank you so much, Dr. Lopez-Candales. I'm going to give you 1 second to wrap up, but first I'm just going to remind everyone, because we had a lot of questions about this. After purchasing the screening from MD Save, you will then call medical imaging at University Health, and that number is 816-404-0690. I'll put that in the chat. It's already in there, but I'll just reiterate it at the bottom, 816-404-0690. to purchase the CT or to schedule, and then you'll bring the voucher with you to your appointment. Dr. Lopez-Candales, thank you so much for your time this afternoon, your lunch and learn. Anything else you'd like us to know?
The most important thing is that you have to be good stewards of your life. If you know that you have risk factors, you have to be more aware. And preventive medicine, sometimes we don't want to put not today, but tomorrow. It has to be done today. You have to take care of yourself. You need to have time to take care of yourself so you can take care of your loved ones. So if you already have risk factors, need to see your doctor to modify your risk. If you don't know what your risk factors are, this is a good time to see your doctor to identify what potential complications you might have in life. Most of the patients say, you know, I'm still young, I'm Superman or Superwoman, I feel great. I don't need to see a doctor. And that's a problem. Those are the ones that are actually going to see the doctor more often than none. So it's a matter to know yourself. And if you don't know how to know yourself, get some help, and somebody can actually help you to know yourself better and minimize your risks of having cardiovascular complications.
Thank you so much for your time. Thank you for all of you who joined us today for the Lunch and Learn. We will let you know when the next one comes up. Dr. Lopez-Candales, maybe next time we can talk about any future breakthroughs or anything that is being worked on that can help us all live healthier. So I appreciate your time very much.
Thank you so much for the invitation.
Thank you. Take care.